welcome to the deep dive. We are speaking directly to you today.
Yes.
You, the newly graduated pediatric nurse who just finished conquering those CNUR 302 lecture notes.
You survived the exams.
Right, exactly. You survived the exams, you know the definitions, and now you are staring down the reality of your very first shifts on the pediatric floor.
And that is a huge transition.
It really is, because reading about a disease in the library is one thing, but standing in a patient room when a child starts going south, well, that's a completely different ballgame.
Yeah.
So our mission today is to take that massive stack of information covering infectious diseases, communicable disorders, and integumentary conditions and transform it into actual clinical mastery.
That shift from theoretical knowledge to bedside application is honestly, it's the steepest learning curve you will face in your career.
Yeah.
We really want to be the bridge for you today.
Because when you're looking at a 3-month-old who is quietly decompensating, you don't have time to flip through a textbook index.
No, you don't. You need to recognize the subtle patterns instantly. You need to understand the underlying pathophysiology, and you absolutely must know your immediate interventions. The stakes are undeniably high.
Yeah, you've heard the phrase, pediatric patients are not just mini adults, countless times in your training, but we need to internalize what that actually means for your daily minute-to-minute nursing practice.
That is the perfect place to start. If we look at the foundational differences in the immune system, according to the source material, a newborn or an infant is basically walking onto the battlefield without armor.
Right. Their immune responses are incredibly underdeveloped compared to the adult patients you might have seen in your med-surg clinical rotations.
They are essentially a blank slate. To put it in clinical terms, infants have significantly lower antibody production compared to older children and adults. They simply cannot mount that same initial defense when they encounter a pathogen.
Because their bodies just haven't learned those specific signatures of different bacteria and viruses yet.
Exactly. So they rely heavily on passive immunity. This is the temporary defense provided by the mother. It's antibodies passed across the placenta during the 3rd trimester of pregnancy, and then later it's supplemented through breast milk, specifically colostrum, which is just packed with secretory IgA.
But how long does that passive immunity actually last? I mean, if a mother passes on antibodies, the infant isn't protected forever, right?
Not at all. That maternal protection is highly transient. Those maternal IgG antibodies actually start to degrade over the first few months of life.
Okay.
By the time an infant is around 3 to 6 months old, that passive immunity has significantly waned. We often refer to this period clinically as the physiological nadir of infancy.
So it's a highly vulnerable window.
Very vulnerable. The maternal antibodies are disappearing, but the infant's own active immune system hasn't fully ramped up its production yet. This is exactly why you will see a massive spike in viral respiratory infections and ear infections right around that 6-month mark.
That makes total sense. And the notes also mention that even when an infant does encounter a bug and fights it off, their immune system has a really poor memory response.
That's a crucial clinical insight. In a mature immune system, once you fight off a specific pathogen, your memory B cells and T cells remember it.
Right, they log it.
Yes, so if you encounter it again, they mount this massive, rapid counterattack before you even feel sick. But an infant's immune system doesn't have that robust memory capacity yet. They can get hit by similar pathogens multiple times and still experience significant illness each time.
Because their immune system is essentially learning from scratch every single time.
Precisely.
Then you add in the physical barriers. A baby's skin and mucous membranes are thinner, they're more permeable. The source notes highlight that their lymphoid organs, the thymus, the spleen, the tonsils, and the lymph nodes are actively developing.
And they are actually quite large relative to their body size compared to adults.
Right, which explains a lot of assessment findings.
It does. That active development is why you will frequently palpate enlarged lymph nodes lymphadenopathy in young children, even with really minor infections. Their lymphatic system is just working overtime.
So when you combine all these factors, the waning maternal antibodies, the lack of immune memory, the permeable skin barriers, and an immature cellular response.
It means a localized infection can become a systemic, life-threatening crisis in the blink of an eye. The buffer zone between mildly ill and critically ill is razor thin in pediatrics.
Which brings us to what you actually do about it. When an infection hits that pediatric floor, what are the tools you are pulling from the medication room? And more importantly, what is the nursing care that surrounds those tools?
The medications themselves are fairly straightforward. For bacterial threats like a group A strep throat, a severe UTI, or a bacterial pneumonia, you will be administering antibiotics.
The usual suspects, right? Amoxicillin, ceflexin, maybe azithromycin.
Exactly. And for a viral infection that requires intervention, like severe influenza or a herpes simplex virus outbreak, you're looking at antivirals like oseltamivir or acyclovir.
And we will discuss the highly specialized antiretroviral therapy, or HART, later when we talk about HIV management.
Yes. But rounding out the pharmacological list, you have your antifungals like fluconazole for systemic issues or topical nystatin for localized yeast, plus your antiparasitics like metronidazole.
And obviously the foundational antipyretics, acetaminophen and ibuprofen, for fever management and comfort.
But dropping a pill in a cup or hanging an IV bag is just the baseline. The real nursing mastery lies in the supportive care. The medication kills the pathogen, but your nursing care keeps the child's body functioning while the drug does its work.
That seems to be the essence of pediatric nursing. Supportive treatments are really the unsung heroes of the care plan.
They absolutely are. Let's say you admit a 9-month-old with severe viral gastroenteritis. The rotavirus is running its course. There is no magic pill to kill that virus.
And the child is dangerously dehydrated because their higher total body water percentage and immature kidneys make them incredibly vulnerable to fluid shifts.
Exactly. So your primary life-saving intervention is fluid resuscitation. You are calculating IV fluid boluses. You are monitoring urine output by literally weighing diapers down to the gram. And you are assessing the fontanelles for sunkenness.
Or take a respiratory infection like RSV. Their airways are already microscopic. You add inflammation and mucus, and they're essentially breathing through a cocktail straw.
That is exactly the visual you need to keep in mind. In that scenario, your supportive care is intense respiratory management. You are managing high-flow nasal cannula oxygen, doing deep suctioning, positioning the child to maximize airway patency.
And constantly assessing for signs of increased work of breathing, like intercostal retractions, nasal flaring, or head bobbing.
Right. You are the one keeping their oxygenation stable, so their immune system has the time and energy to actually clear the RSV.
And as the nurse, you are also the primary gatekeeper for the rest of the unit. You are the one implementing standard, contact, droplet, or airborne precautions the second that patient rolls through the double doors.
You're managing their nutrition when they refuse to eat, managing their pain, and applying those targeted topical treatments.
But everything we've discussed so far is reactive. We're responding to a child who is already sick. The pinnacle of pediatric infectious disease management is proactive, and that rests entirely on vaccination.
Let's get into vaccines, specifically looking at how you handle pre-vaccination screening and patient education, because you will spend a massive portion of your career fielding questions from parents.
The lecture notes heavily emphasize understanding live attenuated vaccines. These contain a version of the living virus that has been severely weakened in a laboratory.
Because it's alive, it mimics a natural infection incredibly well, which produces a very robust, long-lasting cellular and humoral immune response.
The big players in this category are the MMR vaccine for measles, mumps, and rubella, the varicella vaccine for chickenpox, and the rotavirus vaccine.
The clinical catch with live attenuated vaccines is that because the virus is technically alive, you have to be meticulously careful about who receives it. Your pre-vaccination assessment is a hard stop.
You cannot administer a live vaccine to an immunocompromised child, whether that's due to a congenital immunodeficiency, cancer treatment like chemotherapy, or clinical HIV with severe immunosuppression.
Right, because their bodies might not be able to suppress even the weakened laboratory strain. That could lead to an active infection from the vaccine itself.
Who else is on that strict contraindication list for live vaccines?
You must screen out pregnant individuals, any child currently on a high-dose regimen of systemic corticosteroids, or any patient with a documented severe anaphylactic allergy to a specific component of the vaccine, like neomycin or gelatin, depending on the manufacturer.
Missing that screening question during an intake can have catastrophic consequences.
Absolutely catastrophic.
Speaking of catastrophic consequences, the source material highlights a massive, highly relevant public health crisis that is unfolding right now. The 2025 measles, or rubeola outbreak.
Yes.
The data in the notes is staggering. Canada is currently facing multi-jurisdictional outbreaks with over 5,000 confirmed cases. It's gotten to the point where Canada has actually lost its measles-free endemic status. How did we get back here with a disease we effectively eradicated decades ago?
It entirely comes down to dropping vaccination rates. Measles is a unique adversary. To keep it from spreading, a population needs a vaccination rate of about 95% to maintain herd immunity.
Herd immunity being that vital invisible shield that protects the infants who are too young to be vaccinated and the immunocompromised who cannot safely receive the live MMR vaccine.
Exactly. But in various communities across the country, vaccine hesitancy has driven those coverage rates down to around 83%. And when you drop below 95%, you open a window. Measles is opportunistic enough to fly right through it.
The notes state that measles is considered the most contagious infectious disease known to humanity. It says if an unvaccinated person is exposed, they have a 9 out of 10 chance of contracting it.
A 90% infection rate from a single exposure.
That's wild. To understand why it's so unbelievably contagious, you have to look at the pathophysiology and the transmission route.
Measles is caused by a paramyxovirus. It doesn't just spread through large respiratory droplets that fall to the ground within a few feet when someone coughs. It spreads through highly aerosolized particles.
So this is true airborne transmission.
True airborne. The virus can literally hang suspended in the airspace of a room for up to 2 hours after the infected person has left. If an unvaccinated child walks into that empty room an hour later and breathes the air, they can be infected.
That is terrifying from an infection control standpoint. And what makes it a total nightmare for contact tracing is the infectious window.
Yes, a patient is shedding the virus and highly contagious for 4 full days before the classic measles rash ever appears. And they remain contagious for 4 days after the rash erupts.
So by the time the parents see the rash and bring the kid to your triage desk, that child has been at daycare, at the grocery store, and in the waiting room, actively spreading an airborne virus for nearly a week.
Your assessment skills in the triage chair are the only thing stopping a unit-wide outbreak. You have to be able to spot the disease in its prodromal phase, those crucial 2 to 4 days before the rash shows up.
What are the specific red flags you were looking for during that prodromal phase?
You are looking for a very specific constellation of symptoms. First, a high fever, often spiking to 39 or 40 degrees Celsius. They will have profound malaise. They just look universally miserable.
And the absolute hallmarks are the 3 C's, right? Cough, coryza, and conjunctivitis.
Yes. The cough is usually a harsh, dry, hacking cough. Coryza is an extremely severe, profuse runny nose, and conjunctivitis pink eye is a massive red flag. It's often accompanied by photophobia, meaning bright lights cause them actual eye pain.
The notes also mention a very specific oral assessment finding, Koplik spots.
Koplik spots are pathognomonic for measles, meaning if you see them, it is measles.
You need a pen light to assess the buccal mucosa, the inside of the cheeks.
Right. You are looking for tiny bluish-white lesions on a red base. They look a bit like grains of white sand surrounded by a red ring. They usually appear a day or 2 before the skin rash.
If you see the 3 C's, a high fever and Koplik spots, your nursing interventions shift from assessment to immediate containment.
Instantly. You do not leave that child in the main waiting room. You bypass standard triage lines. You initiate airborne precautions immediately.
You get that patient into a negative pressure isolation room, and you ensure that every single healthcare worker entering that room is wearing a fit-tested N95 respirator.
That rapid isolation isn't just an administrative protocol. It's a matter of life and death because the complications of a measles infection are severe, particularly for children under 5, pregnant individuals, and anyone who's immunocompromised.
We aren't just managing a fever and an uncomfortable rash.
Not at all. We are monitoring for secondary bacterial pneumonia, which is actually the most common cause of death. We're watching for severe otitis media that can lead to permanent hearing loss. We're assessing for croup and severe diarrhea.
And then there is the neurological complication, acute encephalitis.
Encephalitis is swelling of the brain, and it occurs in about 1 in every 1,000 measles cases. It can present with high fever, headache, vomiting, stiff neck, drowsiness, and convulsions. It can leave the child with permanent brain damage or deafness.
The notes also outline a complication that is honestly the stuff of nightmares, SSPE, or subacute sclerosing panencephalitis. It's rare, but it is 100% fatal.
SSPE is a devastating progressive neurological disorder. The terrifying aspect of SSPE is its timeline.
Right, because they seem to recover first.
Yes, the child seems to fully recover from the initial measles infection, but a mutated form of the virus manages to hide dormant within the central nervous system. Then, anywhere from 7 to 10 years later, it reactivates.
And it begins to slowly and progressively destroy the brain tissue.
It starts with subtle behavioral changes, progresses to severe seizures, loss of motor control, a vegetative state. And invariably, death. There is no cure.
Which brings us right back to why your role in patient education is so incredibly vital. The MMR vaccine given routinely at 12 months and 18 months is 97% effective at preventing all of this.
But when you are standing at the bedside, you are going to face parents who are terrified by misinformation they've read online.
Let's talk about how you, as a newly graduated professional, handle these conversations impartially and scientifically.
It requires immense patience and a deep understanding of the biology, so you can explain it clearly without sounding condescending. Let's look at the seasonal influenza vaccine as a prime example.
The Canadian Pediatric Society recommends it annually for all children from 6 months up to 18 years. It's usually given via an intramuscular injection, though an intranasal live attenuated version exists.
A parent will inevitably say to you, I'm not letting you give my child that flu shot. I got it 5 years ago, and the shot actually gave me the flu.
How do you dismantle that myth without making the parent feel foolish?
You start by validating their experience, but correcting the biology. You can say, I hear that you felt terribly sick after your last shot. A lot of people experience that. But it's physically impossible for the injectable flu vaccine to give you the flu virus.
Because the vaccine we use is an inactivated or killed virus. It cannot replicate in your body to cause an infection.
Exactly. Then you explain what they actually felt. What you experienced was your own immune system working perfectly. When it recognized the killed virus, it launched an inflammatory response to build antibodies.
So that inflammation is what causes the mild muscle aches, the fatigue, or the low-grade fever they felt for a day or two.
Right. It feels like a mild illness, but it is actually your body building its armor.
Another classic response you'll hear from a parent is, my kid is totally healthy, they eat organic, they play outside, they have a strong immune system, they can fight off the flu naturally, so they don't need a chemical injection.
This is where you pivot the conversation from individual protection to community responsibility. You can explain that they are right. Their healthy 5-year-old probably would survive a bout of the flu with a few miserable days on the couch.
But you emphasize that healthy children are the primary vectors in a community. They spread the virus before they even show symptoms.
You ask them to consider who their child interacts with. Do they have a newborn baby at home who is too young for the shot? Do they visit a grandparent with congestive heart failure? Does a kid in their daycare have asthma?
The healthy child gets the vaccine to create a dead end for the virus, protecting the vulnerable people around them who wouldn't survive the natural infection.
Exactly. We see similar hesitancy with the COVID-19 vaccine. The guidelines recommend an annual dose to keep up with variants, very much like the flu shot protocol.
And a parent might be extremely hesitant, citing everything from lack of efficacy to terrifying side effects.
Transparency is your best tool here. You don't overpromise. You explain that the primary goal of the annual COVID-19 vaccine isn't necessarily to completely prevent a mild sniffly infection.
The primary goal is to prevent severe systemic disease that leads to hospitalization, pediatric ICU admission, mechanical ventilation, death, and the lingering, debilitating effects of long COVID.
And what about the side effects? We've all seen the headlines about heart issues. You can't just ignore those concerns.
Absolutely not. You have to address them head-on with data. You educate them on the highly common expected side effects: localized pain at the injection site, transient fatigue, a low-grade fever, chills, or swollen lymph nodes. Again, framing these as signs of a working immune system.
Then you directly address the rare side effects, specifically myocarditis, which is inflammation of the heart muscle. You acknowledge that, yes, it is a known rare risk, predominantly in adolescent males.
However, you provide the crucial clinical context. The statistical risk of developing severe myocarditis is significantly higher from an actual natural COVID-19 infection than it is from the vaccine.
By laying out the risks versus the benefits objectively, you empower the parents to make an informed, evidence-based decision.
That is exactly how you handle patient education on the floor. Now, the outline gives us a breakdown of a few other highly contagious diseases that you need to be able to identify rapidly. Let's look at fifth disease first, caused by parvovirus B19.
Parvovirus B19 is incredibly common in school-aged children. It spreads through standard respiratory droplets and contact with infected respiratory secretions.
For the child, it's usually a very mild illness.
Yes. It starts with non-specific flu-like symptoms, a mild fever, runny nose, maybe a headache. But a few days later, they develop the classic clinical sign, an intensely red rash on their cheeks that literally looks like they have been slapped.
Which is why it's called slap cheek disease.
Exactly. This is followed by a lacy maculopapular rash that spreads down their trunk and limbs.
But the critical nursing insight here isn't the rash itself, but the timing.
Precisely. The tricky part of fifth disease is its infectious timeline. The child is most contagious during that initial mild flu-like phase before the slap cheek rash ever appears.
So by the time the parent sees the rash and brings them to the clinic, the child is actually no longer contagious and can usually return to school.
Right. But the real danger of parvovirus B19 isn't to the child. It's to pregnant individuals.
If a pregnant nurse on your floor or a pregnant mother visiting a patient is exposed to parvovirus B19, it can cross the placenta.
And it can cause severe fetal anemia, hydrops fetalis, or even miscarriage. If you have an active fifth disease case, pregnant staff should not be assigned to that patient.
Good to know. Let's transition to roseola, also known as sixth disease. This is caused by human herpes virus 6 and primarily targets infants and toddlers between 6 months and 3 years old. The presentation is very distinct.
Roseola is defined by a very specific sequence of events. It begins with an abrupt, very high fever, often jumping to 39.5 or 40 degrees Celsius, seemingly out of nowhere.
And this high fever persists for about 3 to 5 days.
Yes, and despite the intense fever, the infant often seems surprisingly well. They might still be playing and eating reasonably well. Then the fever suddenly breaks. It drops back to normal.
And only after the fever is gone does the rash appear?
Correct. It's a pink, non-itchy, maculopapular rash that starts on the trunk of the body and spreads outward to the neck and arms. It usually fades within a day or two.
But the rash isn't what lands them in your emergency department, is it? It's the fever.
Exactly. The most significant nursing concern with roseola is the risk of febrile seizures. Because the fever spikes so rapidly and so high, it can trigger a seizure in a susceptible infant.
The seizure itself is usually benign and short-lived, but it is utterly terrifying for the parents.
Your patient education focuses heavily on fever management protocols, how to safely administer weight-based doses of antipyretics, the importance of maintaining hydration, and giving them a step-by-step action plan of what to do and what not to do if a febrile seizure occurs at home.
Like placing the child on their side and timing the seizure, rather than trying to restrain them or put anything in their mouth.
Exactly. Keep them safe. Don't intervene physically.
The last disease in this communicable disease section is congenital syphilis. And the public health data in the source notes is incredibly alarming, particularly if you're practicing in certain regions.
The numbers are frankly shocking.
For example, looking at the 2023 data for Saskatchewan, the infectious syphilis rate was listed at roughly 159.3 per 100,000 people. That is an explosive number, well above the national average, resulting in Saskatchewan having the highest rate of congenital syphilis in all of Canada.
It is a profound public health failure that we are seeing these numbers. Congenital syphilis occurs when a pregnant individual with untreated syphilis passes the Treponema pallidum bacterium across the placenta to the developing fetus.
The spear-shaped bacteria infiltrate the fetal tissues, causing widespread, devastating inflammation.
It can lead to stillbirth, extreme prematurity, or severe multi-organ damage.
What does a neonate born with congenital syphilis look like on your assessment?
The signs can be incredibly diverse depending on the severity of the infection. You might see severe hepatosplenomegaly, an enlarged liver and spleen, jaundice, profound anemia, and a highly infectious maculopapular rash, particularly on the palms of the hands and the soles of the feet.
You also look for snuffles, which is a copious, persistent, highly infectious nasal discharge.
Long-term, if undiagnosed, it causes severe bone deformities, dental abnormalities like Hutchinson teeth, and profound central nervous system damage, leading to developmental delays and deafness.
The nursing intervention for a confirmed case of congenital syphilis is rigorous.
It is an intense, zero margin for error protocol. The standard treatment is a strict 10-day course of intravenous aqueous crystalline penicillin G.
As the primary nurse, your responsibilities are immense. You must ensure the IV access remains patent for all 10 days in a fragile neonate, which is a massive challenge in itself.
You must administer the medication on an exact, rigid schedule to maintain therapeutic blood levels of the antibiotic to fully eradicate the spirochete.
You are also implementing strict contact precautions, especially when handling diapers or clearing nasal secretions, as those fluids are highly infectious.
Furthermore, you are coordinating with public health for maternal treatment and contact tracing, which often involves navigating incredibly sensitive psychosocial dynamics.
We've covered a tremendous amount of ground on these infectious diseases. We've talked about how viruses and bacteria exploit the immature immune system. But what happens when that same immune system, instead of just failing to fight, completely overreacts?
That brings us to sepsis.
Yes. What happens when the body's own defense mechanism panics and starts destroying itself? This is the most terrifying scenario you will face on the floor. Let's dive deep into pediatric sepsis.
Sepsis is the ultimate test of a pediatric nurse's assessment skills. To truly grasp sepsis, we need to clearly differentiate it from a standard infection. When a child gets a normal infection, say, a localized urinary tract infection, the pathogen enters, and the immune system responds appropriately. It sends white blood cells to the area, it releases localized inflammatory mediators, it might cause a moderate fever to create an inhospitable environment for the bacteria.
And eventually, it neutralizes the threat. The inflammation is controlled and purposeful.
But sepsis is a totally different beast.
The notes define sepsis as an overactive, dysregulated systemic inflammatory response to an infection.
Dysregulated is the key word. The immune system loses its mind. Instead of a localized attack, it releases a massive, chaotic flood of inflammatory cytokines throughout the entire bloodstream.
This systemic inflammation causes the endothelial lining of the blood vessels everywhere in the body to become highly permeable and start leaking plasma into the surrounding tissues.
It causes widespread vasodilation, meaning all the blood vessels open up at once. This combination of leaking fluids and massive vasodilation causes a catastrophic drop in blood pressure.
The organs are suddenly starved of oxygenated blood. If not stopped, this leads to tissue ischemia, multi-organ dysfunction syndrome, and death.
The golden rule: you must remember all sepsis starts with an infection, but not all infections lead to sepsis. So as the bedside nurse, how do you know when a routine infection is tipping over the edge into sepsis?
You use the CNUR criteria.
Right.
CNUR stands for Systemic Inflammatory Response Syndrome. This is your definitive objective assessment checklist.
To meet the clinical criteria for CNURs, your pediatric patient must exhibit at least 2 of 4 specific signs, and the most critical caveat to remember one of those 2 signs must be an abnormal temperature or an abnormal white blood cell count.
You cannot diagnose CNURs based on just a fast heart rate and fast breathing alone.
Exactly.
Let's break down those 4 criteria in excruciating detail because this is the math that saves lives. Number 1 is temperature. You are looking for a core temperature greater than 38.5 degrees Celsius. And this is where many people miss it, less than 36 degrees Celsius. Wait, so if I'm assessing a neonate, a dropping temperature is a CNURS criteria.
Yes.
I think a lot of us might be hardwired to only panic when the thermometer spikes. Why does the temperature drop?
It's an excellent question. In older children, a high fever is the standard response as the hypothalamus cranks up the body's thermostat to fight the bug. But neonates and young infants have highly immature thermoregulation systems.
Okay, so they can't handle the stress.
When they are hit with a massive, overwhelming infection, their metabolic reserves are rapidly depleted. Their system essentially crashes, and they lose the ability to maintain their body heat. Hypothermia in a neonate with a suspected infection is often a much more ominous and late sign of sepsis than a fever.
Wow. Okay, number 2 on the CNURS list, heart rate. You are looking for tachycardia, a heart rate significantly above the normal baseline for their specific age group. Or, conversely, in infants under 1 year old, you are looking for bradycardia.
Again, similar to the temperature response. Initially, the heart races to try and pump whatever blood it can to the starving organs. But as the child exhausts their compensatory mechanisms, or if the hypoxia becomes severe, the heart muscle itself begins to fail and the heart rate drops.
A dropping heart rate in a previously tachycardic sick infant is a pre-arrest warning sign. You have minutes to intervene.
Minutes.
Number 3, respiratory rate. You are looking for tachypnea, an elevated respiratory rate well above normal limits, or the sudden need for mechanical ventilation for an acute disease process.
Their body is becoming acidotic from the failing organs, and they are breathing rapidly to try and blow off excess carbon dioxide to balance their blood pH.
And finally, number 4, white blood cells. You need a CBC differential here. The count could be drastically elevated, indicating a massive immune push. It could be abnormally low, meaning the immune system is exhausted or suppressed by the virus.
Or you might see greater than 10% immature neutrophils, often referred to clinically as BANs. This indicates a left shift.
The infection is so severe that the bone marrow is hastily pumping out unfinished premature white blood cells to the front lines because all the mature fighting cells have been destroyed.
So two of those four criteria, including abnormal temp or abnormal WBCs, and your patient has CIRS, if they have CIRS plus a suspected or confirmed source of infection, they officially have sepsis.
But let's bring this back to the subtle nature of pediatrics. An infant isn't going to tell you they feel septic. What does this look like when you walk into the room?
It can be chillingly quiet. You might walk in and notice the baby is just unusually lethargic. They aren't tracking you with their eyes. They're completely refusing to feed, or they are inconsolably irritable with a weak, high-pitched cry.
Their skin might look mottled, a blotchy, purplish, marbled appearance, indicating poor perfusion.
Their capillary refill time will be delayed, taking more than 3 seconds for the color to return when you press on their nail bed. If you see these subtle signs and their vitals are slipping into CIRS territory, your internal alarm must go off.
The moment that alarm goes off, a clock starts. In nursing, we call this the golden hour. You do not have time to wait for the attending physician to finish their rounds. You have to initiate the sepsis bundle protocols immediately. Walk us through the exact sequence of interventions.
The sequence is non-negotiable. Step 1 is diagnostic. Before you give them a single drop of medication, you absolutely must obtain cultures.
You draw blood cultures, you obtain a urine culture, often via a sterile in-and-out catheterization, and you check inflammatory markers like CRP and procalcitonin alongside a venous blood gas and a lactate level to assess tissue perfusion.
Now, why is it so absolutely critical to get those cultures drawn before the antibiotics? If the kid is dying of an infection, shouldn't the antibiotics be the very first thing?
It seems counterintuitive, but if you administer a powerful broad-spectrum IV antibiotic before you draw the blood, that antibiotic begins killing the bacteria in the bloodstream within minutes.
When the phlebotomist finally draws the blood half an hour later and sends it to the lab, the sample might be sterile.
The lab won't be able to grow the bacteria in the petri dish. If they can't grow it, they can't identify exactly what pathogen it is, and they can't tell you which specific narrow-spectrum antibiotic will be most effective.
You have essentially blinded the medical team. You must draw the cultures first to capture the live bacteria, and then within minutes, you hang the broad-spectrum IV antibiotics to start fighting the fire.
While those antibiotics are infusing, you are simultaneously moving to step 2, fluid resuscitation.
Remember that massive vasodilation and leaky blood vessels we talked about? Their blood pressure is tanking. You need to rapidly refill the vascular space to maintain perfusion to the brain, heart, and kidneys.
You will aggressively administer isotonic IV fluids, usually normal saline or lactated ringers. We aren't talking about a slow drip. We are talking about rapid boluses, often 20 milliliters per kilogram of body weight, pushed in over 5 to 10 minutes and repeated as needed based on their response.
And if you've pumped them full of fluids and their blood pressure still isn't coming up,
If fluids fail to restore perfusion, they have progressed to fluid refractory septic shock. You immediately move to step 3, vasoactive medications.
these are incredibly potent drugs like epinephrine, norepinephrine, or dopamine administered via a central line. They chemically force the dilated blood vessels to constrict and stimulate the heart muscle to pump harder, artificially sustaining their blood pressure to keep them alive.
Throughout all of this, you are providing step 4, continuous oxygenation and ventilation support, because their cellular demand for oxygen is skyrocketing.
All of these interventions, identifying the CIRS criteria, drawing cultures, hanging antibiotics, pushing fluids, and preparing pressors, must happen within that first golden hour. It is the definition of high-stakes, rapid response nursing.
It is exhausting, but it is deeply rewarding when you catch it early and turn them around. Sepsis is an acute, explosive crisis. But as a pediatric nurse, you will also manage complex, chronic infectious processes that require an entirely different set of clinical and psychosocial skills. This brings us to pediatric HIV infection.
Let's lay the physiological groundwork for HIV. Human immunodeficiency virus is a retrovirus. Its primary target is the CD4 cells, also known as T helper cells.
You can think of CD4 cells as the commanding generals of the immune system. They are the ones who detect a threat and signal the B cells to make antibodies and the killer T cells to attack.
HIV invades these CD4 cells, uses their internal machinery to replicate itself, and then destroys the cell in the process. Without treatment, the virus steadily annihilates the immune system's command center.
This progresses to acquired immunodeficiency syndrome, or AIDS, leaving the child totally defenseless against opportunistic infections that a healthy body would normally brush off easily.
The epidemiology in pediatrics is quite specific. While older adolescents might contract HIV through sexual contact or shared needles, the vast majority of HIV cases in children under 13 are the result of vertical transmission, meaning mother-to-child transmission.
This can occur in utero during pregnancy, through exposure to maternal blood and fluids during the physical birthing process, or postnatally through breastfeeding as the virus is present in breast milk.
When you are assessing an infant or young child with undiagnosed HIV, what are the clinical manifestations? They aren't going to present with a neon sign. The early signs can be quite insidious and chronic.
You are looking for a pattern of relentless low-level illness. The infant might have recurrent bacterial infections, frequent ear infections, pneumonias, or severe skin infections that don't respond well to standard treatments.
You will often see failure to thrive, meaning they are not gaining weight or growing along their expected percentiles. They might have chronic unexplained diarrhea, persistent oral thrush that keeps returning despite antifungal treatment, widespread swollen lymph nodes, and hepatosplenomegaly.
As the disease advances and the CD4 count drops further, they become vulnerable to severe opportunistic infections. A classic pediatric example is pneumocystis jirovecii pneumonia, or PCP, a fungal pneumonia that is incredibly rare in healthy individuals, but devastatingly common and lethal in immunocompromised children.
Now, the source notes highlight a vital diagnostic nuance for pediatric HIV that every nurse must understand. If a mother is known to be HIV positive and she gives birth, you obviously need to test the baby. But the notes state you cannot just use a standard HIV antibody test on a newborn. Why is that?
This is a critical piece of medical science to understand. Standard HIV tests, like the ELISA test, do not look for the virus itself. They look for the antibodies the body has produced in response to the virus.
But remember what we discussed in part 1 about passive immunity. During the third trimester, maternal IgG antibodies freely cross the placenta to protect the baby. If the mother has HIV, her HIV antibodies will cross the placenta.
Therefore, the newborn will have circulating HIV antibodies in their blood, regardless of whether the actual virus was transmitted. If you run an ELISA test on a 2-month-old, it will come back positive, but it might be a false positive reflecting the mother's immune system, not the baby's.
Exactly. It can take up to 18 months for those maternal antibodies to fully clear from the infant system.
So how do you actually diagnose an infant under 18 months old?
You must use virologic testing, specifically an HIV, DNA, or RNA polymerase chain reaction, or PCR test. A PCR test doesn't care about antibodies. It looks for the actual genetic material, the DNA or RNA, of the HIV virus itself circulating in the infant's blood.
If the PCR finds the viral genetics, the infant is infected. These tests are typically run at multiple intervals shortly after birth, at 14 to 21 days, at 1 to 2 months, and again at 4 to 6 months to definitively confirm or rule out infection.
Once the child is 18 months or older and maternal antibodies are gone, you can confidently transition to using standard antibody tests like the ELISA, confirmed by a Western blot.
Let's discuss the nursing interventions and treatments for a child living with HIV. We've moved past the acute crisis and into chronic, lifelong management. The primary medical intervention is HAART, highly active antiretroviral therapy.
HAART is a customized daily cocktail of multiple antiretroviral drugs from different classes. They work together to interrupt the virus's replication cycle at different stages.
The goal is to suppress the viral load in the blood to undetectable levels, which halts the destruction of the CD4 cells and allows the immune system to recover and function normally.
But the challenge for you, the pediatric nurse, isn't just administering the drug in the hospital. The challenge is ensuring adherence when they go home.
Adherence is the monumental hurdle in pediatric HIV care. We are asking parents to give a toddler multiple medications every single day at exact times without fail.
The liquid formulations often taste vile. The pills can be large and difficult to swallow. The toddler might spit it out, vomit, or throw a tantrum. It is exhausting for the family.
But as the nurse, you have to emphasize that missing doses or taking them irregularly is incredibly dangerous. It allows the virus a window to replicate and mutate, rapidly developing resistance to that specific drug cocktail.
If they burn through their medication options due to non-adherence, their treatment pathways narrow significantly. You will spend hours working with families on creative administration strategies, mixing meds with specific foods if clinically allowed, using behavioral reward charts, and providing immense psychological support.
The notes also mention a very specific prophylactic intervention for infants born to HIV-positive mothers, regardless of whether their PCR tests have come back positive yet.
Yes. Because that first year of life is so vulnerable, and because PCP pneumonia is so lethal, All infants born to HIV-positive mothers are prophylactically started on an antibiotic called trimethoprim sulfamethoxazole, commonly known as TMP-SMX or Septra, usually starting at 4 to 6 weeks of age.
This isn't an antiretroviral. It doesn't treat the HIV. It is given solely to prevent pneumocystis pneumonia from taking hold while we wait to determine the infant's true HIV status and optimize their heart regimen.
Managing an HIV-positive child really forces you to step back from the microscope. You aren't just managing viral loads and CD4 counts. You are managing a growing human being dealing with a highly stigmatized chronic illness. This perfectly transitions into the vital concept of holistic assessment.
A holistic assessment means recognizing that the disease does not exist in a vacuum. The child's physical growth, cognitive development, and emotional well-being are all intertwined with their medical diagnosis. When you are assessing a chronically ill child, your checklist expands exponentially.
You are meticulously tracking their physical growth and nutrition. You are plotting their height, weight, and head circumference on growth charts at every visit, looking for any downward trends that indicate the disease is demanding too many calories.
You are assessing their developmental milestones. Are they sitting up, walking, and talking at the appropriate ages? Or is the illness causing neurological delays?
You are evaluating their cognitive function and school performance. Are frequent hospitalizations causing them to fall behind? Are there any subtle changes in their problem-solving abilities or attention span?
You must adapt your communication strategies, ensuring you are explaining their illness and their treatments using age-appropriate, non-threatening language that empowers them rather than terrifies them.
And perhaps most importantly, you are constantly assessing their psychosocial development and behavioral responses. A chronic illness imposes massive stress on a child. A normally independent 5-year-old who suddenly starts wetting the bed again, refusing to speak, and clinging desperately to their mother isn't just misbehaving.
Exactly. That behavioral regression is a coping mechanism. It is a profound symptom of the psychological trauma of chronic illness, painful procedures, and disrupted routines.
If you only look at their lab work and ignore the fact that they are emotionally withdrawing, you are failing them as a nurse. Your holistic assessment catches these nuances so you can integrate child-like specialists, social workers, and psychological support into their comprehensive care plan.
We are entering the final major pillar of this deep dive. We've conquered the immune system and high-risk systemic infections. Now we bring our focus to the body's largest organ, the physical barrier itself, the skin. Let's delve into pediatric integumentary disorders and assessments.
To understand why children are so prone to massive skin infections and severe reactions, we have to look at the anatomy and physiology. Pediatric skin is structurally and functionally immature compared to adult skin.
The skin has three main layers: the epidermis on the outside, the dermis in the middle, and the subcutaneous tissue underneath. In a young child, the epidermis and dermis are physically thinner. They literally have less armor.
That thinness means topical medications are absorbed much more rapidly and deeply into their systemic circulation, which is why you have to be so careful with the dosage of steroid creams. Furthermore, infant skin has a significantly higher water content. The cells are loosely bound.
This means when the skin barrier is compromised, like with a severe burn or a massive rash, they can lose intracellular fluids and become clinically dehydrated at a shocking speed.
Their melanocytes, the cells responsible for producing pigment and providing protection against ultraviolet radiation, are underdeveloped, making them highly susceptible to sun damage. And crucially, their subcutaneous fat layer is much thinner.
The lack of subcutaneous fat has dual consequences. First, they have less physical cushioning, making them more prone to bruising and mechanical trauma. But more importantly, subcutaneous fat is the body's insulation.
Without it, infants have highly immature temperature regulation. They lose body heat to their environment rapidly. If you leave a sick infant undressed on a cold examination table for too long, you can easily trigger hypothermia and cold stress, which massively increases their metabolic oxygen demand.
Knowing how vulnerable the organ is, your assessment skills need to be incredibly precise. A dermatological assessment starts with the subjective history. You are interviewing the parent and the child. You are asking about pruritus, the clinical term for itching. But if the infant is nonverbal, how do you assess for pruritus?
You look for the secondary signs. You look for excoriations, scratch marks, or raw areas where they've been rubbing against the crib sheets. You ask the parents if the infant is exceptionally restless, constantly writhing, or if their sleep has been severely disrupted, which is a classic sign of intense, unrelenting itching.
You also gather a detailed history of recent exposures, New laundry detergents, new soaps, contact with strange plants on a camping trip, a history of family allergies, or any known sick contacts at daycare.
Then you move to the objective physical assessment. And this is a section of the source material that demands our absolute, undivided attention. Historically, medical and nursing textbooks have predominantly focused on how dermatological conditions present on light or Caucasian skin.
This has led to severe diagnostic delays and inequitable care for patients with darker skin tones. As a modern, evidence-based nurse, you must be proficient in accurately assessing color changes across the entire spectrum of human skin tones.
This is non-negotiable for equitable care. Let's walk through the major physiological color changes carefully, comparing the assessment techniques. We will start with cyanosis, which indicates hypoxia or reduced oxygen saturation in the blood.
In a patient with light skin, cyanosis is relatively obvious. You're looking for a bluish tinge that appears primarily in the palpebral conjunctiva, the tissue lining the lower eyelid, the nail beds, the earlobes, the lips, the soles of the feet, and the palms of the hands. But you cannot rely on looking for a blue color in a patient with dark skin.
Correct. The melanin in darker skin tones masks that bluish hue on the skin surface. To accurately assess for cyanosis in dark skin, you must evaluate the mucous membranes. You are closely examining the lips, the gums, and the oral mucosa inside the mouth. Instead of a blue color, you are looking for an ashen, gray, or whitish discoloration.
Next is pallor. Pallor indicates a decrease in blood flow or a decrease in red blood cells as seen in severe anemia or early shock. In light skin, it presents as a loss of the normal rosy glow, particularly noticeable in the face, making the skin look unusually pale or white.
In dark skin, general pallor can be easily missed if you don't know where to look. You must inspect the palms of the hands and the soles of the feet. You will notice a distinct reduction in the darkness of the palmar and plantar creases.
You should also pull down the lower eyelid and assess the conjunctiva, which will appear pale or white instead of its normal healthy pink. In patients with brown skin tones, widespread pallor often presents as a more yellowish-brown, dull appearance.
Let's talk about erythema. This is redness of the skin indicating inflammation, a localized infection, a fever, or an allergic reaction. In light skin, erythema is visually obvious. The skin turns bright red or pink anywhere the inflammation is occurring. But in dark skin, visual redness is incredibly difficult, if not impossible, to see.
Because you cannot rely on a visual color cue, assessing erythema in dark skin forces you to heavily engage your palpation skills. You must use the back of your hand to feel the skin for localized increased warmth compared to the surrounding tissue.
You must palpate gently to feel for localized edema or swelling. Visually, you might notice that the inflamed skin looks unusually shiny, taut, or smooth as it stretches over the underlying swelling. Furthermore, instead of a bright red flush, the inflamed area might have a subtle, deep burgundy or purplish undertone.
Ecchymosis and petechia. Ecchymosis is a large bruise, bleeding under the skin from trauma. Petechia are tiny, pinpoint, non-blanching hemorrhages caused by capillary bleeding, often a sign of severe systemic infection or platelet disorders. In light skin, bruises go through a spectrum of purplish blue to yellow-green, and petechia look like tiny red dots.
In dark skin, a fresh bruise will typically appear dark purple or dark brown, but it can blend insignificantly. Your best assessment technique here is symmetry. You compare both sides of the body simultaneously.
If you suspect a bruise on the right thigh, compare it to the left thigh to look for an asymmetrical, darker patch. As for petechia, those tiny red dots are almost always completely invisible on dark skin surfaces.
If you suspect a petechial rash, which is a medical emergency in a febrile child, you must meticulously inspect the oral mucosa, the hard palate, the conjunctiva of the eyelids, and the sclera of the eyeball itself, as these are the only places they will be visibly apparent.
Finally, jaundice. This is the yellow staining of the skin and tissues caused by high levels of bilirubin in the blood, indicating liver dysfunction or massive red blood cell breakdown. In light skin, the yellowing is obvious on the skin surface, the fingernails, the oral mucosa, and the sclerae of the eyes.
In dark skin, the yellow discoloration on the general skin surface is heavily masked. To reliably assess for jaundice, you must bypass the skin and inspect the sclera of the eyes, ensuring you are looking at the portion of the sclera near the iris, as the outer edges can sometimes have benign pigmented deposits.
You also inspect the hard palate inside the mouth and the palms of the hands and soles of the feet, looking for that distinct yellowing.
Having mastered those assessment techniques, let's apply them to the specific infectious skin conditions you will be managing. We will divide these by their causative agents, starting with viral infections. The quintessential example is chickenpox, caused by the varicella zoster virus.
Chickenpox is fiercely contagious. It spreads via both airborne transmission, meaning it can linger in the air and direct contact with the fluid from the blisters. The disease presents with a classic, intensely itchy rash that progresses through distinct stages.
It begins as flat red spots called macules. These elevate into raised bumps called papules. The papules quickly fill with clear fluid to become vesicles or blisters, which look like a dewdrop on a rose petal. Finally, the vesicles rupture and dry out, forming hard crusts or scabs.
And the absolute hallmark clinical sign of varicella is that you'll see all of those stages present on the body simultaneously.
Exactly. You will assess the child and see fresh, flat macules erupting on their back, fully formed fluid-filled vesicles on their chest, and older healing crusts on their face, all at the same time.
The notes also explicitly detail how this classic progression looks different on darker skin tones.
Yes. On darker skin, those initial flat macules and raised papules are much more subtle and harder to see visually. You might feel them before you see them. When they develop into vesicles, the surrounding rose petal base won't be a bright red ring.
It may appear as a faint ring of dark red or violet, or the surrounding skin might look entirely normal.
In the final healing stage, when the crusts fall off, the intense inflammation often leaves behind post-inflammatory hyperpigmentation areas of darker skin or hypopigmentation areas of lighter skin that can take months or even years to fully fade.
As the nurse, your goals for a chickenpox patient are heavily focused on supportive care and complication prevention. There is no cure for the active virus. You administer antipyretics for the fever, you enforce strict airborne and contact isolation, and you employ massive efforts to relieve the intense pruritus. Why is stopping the itching so medically important?
Because scratching is the gateway to the most common complication, secondary bacterial skin infections. If a child uses dirty fingernails to violently scratch open a varicella blister, they are introducing staph or strep bacteria directly into the open wound, leading to severe impetigo or deep tissue cellulitis.
You prevent this by keeping their fingernails cut extremely short, having them wear mittens to sleep, providing soothing oatmeal baths, and administering systemic antihistamines.
You also must closely monitor for severe systemic viral complications, particularly pneumonia or encephalitis, which are life-threatening risks, especially for immunocompromised children.
Another prevalent viral condition is hand-foot-mouth disease, primarily caused by the Coxsackie A16 virus. The name essentially tells you the clinical presentation. It features a classic triad, painful ulcerative sores in the mouth, and a vesicular rash on the palms of the hands and the soles of the feet.
What differentiates the hand-foot-mouth rash from chickenpox during your assessment is the nature of the vesicles themselves. In Coxsackie, the blisters are typically oval-shaped. They often have a grayish center surrounded by a red or darker halo, and crucially, they're usually not itchy.
Because it spreads rapidly through fecal, oral, and respiratory routes, and because there is no vaccine, your absolute primary intervention is patient education, focused relentlessly on aggressive hand hygiene, particularly after diaper changes.
The mouth sores can be incredibly painful, leading to refusal to drink, so monitoring for dehydration is also key.
Moving from viral to bacterial skin infections. Let's look at impetigo. This is usually caused by Staphylococcus aureus or Group A beta-hemolytic streptococcus. It is incredibly common in toddlers and highly contagious.
Impetigo typically starts as a simple red macule, often occurring around the nose or mouth where the skin is frequently wiped and irritated. This macule quickly becomes a vesicle, which ruptures easily. The defining feature that seals your assessment is what happens next. The exudate dries to form very thick, distinct honey-colored crusts.
The nursing care here involves a specific sequence. You can't just smear antibiotic ointment over the top of those hard crusts.
Correct. The topical antibiotic cannot penetrate the crust to reach the bacteria. Your intervention involves applying warm, moist compresses to gently soften the crusts.
Once softened, you carefully remove the crusts using a sterile technique, and then you apply the topical antibacterial ointment, such as mupirocin or Bactroban, directly to the raw underlying lesion.
Because it's so contagious, strict contact precautions and separate towels and washcloths for the child at home are vital teaching points.
What about distinguishing between cellulitis and folliculitis? They are both bacterial, but they are anatomically and clinically distinct.
Cellulitis is a severe, deep tissue infection of the dermis and subcutaneous layers. It often originates from a minor skin break, a tiny cut, a mosquito bite, or a scratched eczema patch. The affected skin becomes diffusely red, significantly swollen, noticeably warm to the touch, and firm or indurated. It is incredibly painful.
Because it's deep, it can spread rapidly and progress to a systemic bloodstream infection. What is this specific nursing intervention for tracking cellulitis?
You must objectively monitor its progression. You literally take a skin-safe surgical pen and trace the exact outer border of the redness upon admission.
This allows you and the nurse taking over on the next shift to see definitively if the margin of infection is shrinking in response to the IV antibiotics or if it is rapidly expanding, which would require an immediate change in the medical plan.
You also apply hot, moist compresses to increase blood flow and draw out the infection and elevate the affected limb to reduce edema.
Folliculitis, conversely, is much more superficial. It is an infection specifically localized within the hair follicles, often caused by friction, sweating, or irritation. Think of a teenager wearing tight football pads. You will assess small, red, itchy bumps, often with a tiny pustule at the center, exactly where the hair exits the skin.
The nursing management for folliculitis is less intense, but requires specific patient teaching. You recommend warm compresses and antibacterial soaps. But the crucial education piece, especially for adolescents, is telling them emphatically not to pop, squeeze, or pick at the pustules.
Squeezing forces the bacteria deeper into the follicle, transforming a minor surface infection into a deep, painful furuncle or boil, and leading to permanent scarring.
Let's shift to fungal infections. The notes highlight Tinea corporis, universally known as ringworm, though it has absolutely nothing to do with the worm.
It's caused by a dermatophyte fungus. Your assessment will reveal a very classic, unmistakable lesion, a distinct round or oval scaly patch that clears in the center as it expands outward, creating a red, inflamed ring shape.
It's highly contagious through direct contact, and children often contract it from infected family pets like kittens or puppies, or from contaminated locker room floors. Treatment involves strict application of topical antifungal creams like clotrimazole, continuing for at least a week even after the lesion visibly disappears to ensure eradication.
Another major fungal player is candidiasis, caused by the yeast Candida albicans. This opportunistic yeast thrives in warm, dark, moist environments. In pediatrics, you will most commonly see it in two places. On an infant's bottom, it presents as a severe candidal diaper dermatitis.
A yeast diaper rash looks very different from a standard irritant diaper rash. A candidal rash is a massive, beefy red, sharply demarcated plaque. The defining assessment finding is the presence of satellite lesions. These are smaller, distinct red spots scattered outside the main border of the rash. It looks wet and inflamed.
And if that same yeast proliferates in the infant's mouth, we call it oral thrush. You will assess thick, white, curd-like plaques on the tongue, the palate, and the inner cheeks. It looks remarkably like milk curds. How do you definitively know it's thrush and not just leftover formula?
You try to gently wipe it away with a gloved finger or a swab. Leftover milk will wipe away easily, revealing healthy pink tissue underneath. Oral thrush cannot be wiped off easily. The plaques are adhered to the mucosa.
If you rub hard enough to remove them, the underlying tissue will be raw, inflamed, and will likely bleed. Treatment for both the diaper area and the mouth involves targeted antifungals, typically topical nystatin or oral fluconazole.
If the infant is breastfeeding, the mother's nipples must also be treated simultaneously to prevent them from passing the yeast back and forth.
We are down to the parasitic infections, which require the most intensive patient and environmental education. Let's look at scabies. This is caused by a microscopic female mite, Sarcoptes scabii, that burrows into the stratum corneum, the outermost layer of the skin, to lay her eggs and deposit feces.
The pathophysiology of the scabies symptom is fascinating and cruel. The intense, maddening, unrelenting itching is actually a delayed type IV hypersensitivity reaction, an allergic response to the mite's feces and eggs.
Because it's a delayed immune response, a newly infected child will not start itching until 30 to 60 days after they are initially infested. During those 2 months, they are entirely asymptomatic but highly contagious, blindly spreading the mites to everyone they sleep next to or play closely with.
When you are performing your assessment, the location of the burrows is highly age-dependent, isn't it?
Yes. In infants and children under 2 years of age, you must meticulously assess the palms of the hands, the soles of the feet, the ankles, and even the scalp and face. In older children and adolescents, the mites prefer warmer, protected areas.
You must check the webs between the fingers, the wrists, the armpits, and the groin. You are looking for tiny, thread-like gray or white burrow lines, often ending in a tiny papule, though these are frequently obliterated by the child's violent scratching.
The treatment and the teaching for scabies are an immense undertaking. The medical intervention is the application of a scabicide, usually permethrin 5% cream. You instruct the parents to massage this cream over the child's entire body, from the neck down, or including the head, Infants leave it on for 8 to 14 hours, usually overnight, and then wash it off. But applying the cream is only 10% of the job.
Environmental eradication is the other 90%. The scabies mite can survive off the human body in fabrics for 48 to 72 hours. You must emphatically teach the family that every single person living in the household and any close physical contacts must be treated with the permethrin cream simultaneously, regardless of whether they're itching yet, because of that 60-day incubation window.
Furthermore, on the morning the cream's washed off, all clothing, bed sheets, blankets, and towels used in the last 72 hours must be gathered, washed in the hottest water possible, and dried on the highest heat setting to kill the mites and eggs. Anything that cannot be washed must be sealed in airtight plastic bags for at least 3 days.
The other famously dreaded parasite is head lice, or pediculosis scapitis. The primary symptom is intense itching on the scalp or a tickling, crawling sensation. A brilliant assessment question to ask the parent is, does the itching seem worse when they go to bed?
That's a great targeted question because lice are highly active in the dark. Your physical assessment requires a bright light, a magnifying glass, and sectioning the hair. You are not primarily looking for the adult crawling bugs. They are fast and evade light. You are looking for the nits.
Nits are the tiny, teardrop-shaped eggs. The female louse secretes a powerful glue that attaches the nit to the hair shaft very close to the scalp, particularly at the nape of the neck and behind the ears where it's warmest. They are firmly cemented. Unlike dandruff, you cannot simply flick a nit off the hair. It must be physically pulled down the entire length of the hair shaft.
The nits hatch in 7 to 10 days. The patient teaching here is largely focused on dispelling panic and myths. What are the key facts parents need to know?
First, you reassure them that lice have nothing to do with poor hygiene or dirty homes. Lice actually prefer clean hair. Second, dispel the jumping myth. Lice cannot jump and they cannot fly. They do not have the anatomy for it. They transmit purely through direct, prolonged head-to-head contact, or occasionally through shared has or brushes.
Third, their survival outside the host is very poor. An adult louse will starve to death within 48 hours without a human blood meal. The treatment involves a medicated pediculicide shampoo, but the absolute most critical intervention is meticulous. Manual nit removal using a fine-tooth metal comb, repeated every 2 to 3 days for 2 full weeks to catch any newly hatched nymphs before they can lay more eggs.
Similar to scabies, unwashable items like stuffed animals should be sealed in a plastic bag for 48 to 72 hours to starve any stragglers.
We will wrap up our clinical content by looking at a few inflammatory conditions and common neonatal skin findings that you need to be able to identify confidently. Let's start with eczema, clinically known as atopic dermatitis. Eczema is a chronic, relapsing inflammatory skin disorder that causes profound dryness, intense itching, and red weeping patches. It is heavily linked to a genetic predisposition.
It is part of what we call the atopic triad, which consists of atopic dermatitis, asthma, and allergic rhinitis, or hay fever. If a child presents with severe eczema, you must have a high clinical suspicion that they will eventually develop asthma or severe environmental allergies as they grow. The nursing management goals for eczema are multifaceted.
The primary goal is aggressive hydration. The skin barrier is defective and loses moisture constantly.
You teach the parents to use thick, fragrance-free emollients or ointments immediately after a lukewarm bath to lock the moisture into the skin. You must help them identify and ruthlessly eliminate triggers. This could be scratchy wool clothing, harsh laundry detergents, extreme temperature changes, or specific food allergies.
During acute flare-ups, you will educate them on the appropriate use of topical corticosteroids to rapidly reduce the inflammation. And just like with chickenpox, a major goal is preventing secondary bacterial infections. Eczema is incredibly itchy, and constant scratching breaks down an already fragile barrier, inviting staph infections.
Contact dermatitis is another inflammatory condition, but it is strictly an exogenous response. It is a localized skin inflammation caused by direct physical contact with an external irritant or an allergen.
The classic examples are a severe blistering rash from brushing against poison ivy, a localized red patch from the nickel in a belt buckle, or a spreading rash from a new brand of baby wipes. The assessment key here is the shape and location of the rash. It often directly mirrors the object that touched the skin, like a straight line where a plant brushed the leg.
The management is entirely dependent on playing detective, identifying the specific trigger, removing the irritant, washing the skin thoroughly, and using topical steroids or oral antihistamines to calm the localized immune reaction.
Finally, as a pediatric nurse, you're going to encounter panicking new parents who notice strange spots on their perfect newborn. You need to be able to rapidly identify a few common, completely benign neonatal skin conditions so you can provide immediate reassurance. For instance, melia. Parents will often point to tiny, firm, white papules across their newborn's nose and cheeks and ask if it's an infection or baby acne.
You confidently reassure them that it is neither. Milia are simply tiny cysts formed by trapped keratin and sebaceous material under the skin. They are entirely benign. They are not infectious.
The crucial patient teaching here is to emphatically tell the parents not to try and pop or squeeze them. Squeezing will only cause painful inflammation and potential scarring. Melia will spontaneously resolve and disappear on their own within the first few weeks of life.
You might also assess erythema toxicum neonatorum, which sounds terrifying, but is just a harmless, splotchy, flea bite-like rash that appears in the first few days of life and vanishes without treatment. Or seborrheic dermatitis, commonly known as cradle cap, which presents as thick, greasy, yellowish, flaky scales on the scalp. It is managed simply with gentle washing and massaging with baby oil or a soft brush.
And importantly, you must be able to properly identify and document Mongolian spots, which are now more accurately and clinically referred to as dermal melanocytosis. These are flat, irregular, blue-gray, or slate-colored patches that appear most commonly on the lower back, buttocks, or shoulders of infants, particularly those with darker skin tones, African, Asian, Hispanic, or indigenous descent.
They are completely benign concentrations of pigment cells deep in the dermis. The critical nursing responsibility here is meticulous documentation upon admission. Because they look remarkably like deep bruises, if they are not documented at birth, they can be tragically misidentified later as signs of physical abuse by a different healthcare provider.
And there it is. We have traversed an absolute massive amount of clinical territory today. We started by dismantling the foundational vulnerabilities of the pediatric immune system, understanding exactly why infants are so defenseless.
We navigated the intense, rapid-fire, high-stakes interventions required to save a life during the sepsis golden hour.
We explored the complexities of chronic pediatric HIV management, and finally, we mapped out the intricate details of pediatric integumentary assessments across all skin tones and conditions. You are now equipped with the why, the how, and the what's next. You have the tools to translate the theories from Lecture 2 into true, life-saving clinical readiness on the pediatric floor.
You are thoroughly prepared for the clinical tasks. But before we sign off, I want to leave you with a broader, more philosophical question to consider as you tie your shoes for your next shift. We discussed the staggering 2025 measles data over 5,000 cases in Canada alone. We are watching a highly preventable, theoretically ancient disease storm back into our communities entirely due to dropping vaccination rates and the rapid spread of digital misinformation.
It's so pretty.
In an era where a terrifying viral rumor spreads faster than the paramyxovirus itself, how does your identity as a pediatric bedside nurse fundamentally evolve? Are you no longer just a bedside caregiver administering antibiotics and hanging IV fluids? Are you now the primary frontline public health educator responsible for slowly, patiently rebuilding the wall of herd immunity, one parent conversation at a time? It is an incredibly heavy mantle to wear, but it is the reality of modern nursing, and it is yours to carry.
That is a profound perspective to carry onto the floor with you. Thank you for spending this hour diving deep with us. Keep questioning the subtle signs, keep assessing your patients with fresh, critical eyes, and keep learning and advocating as you step confidently into your new role. You are going to be an absolutely incredible pediatric nurse. We will see you on the next deep dive.